Okay. All right, let's begin. And this is where we ended. This is a slide that we were talking about. It's a very important slide because it gives you an idea why the heart is very vulnerable to diseases, specifically chest pains. This slide explains why you are likely to have chest pains. But also it explains why you should change your diet. And this will become clear in the next 2 or 3 slides. So essentially, we are following the patterns of blood flow in the coronary blood vessels. And this happens also, as we said before, this happens to the blood flow that are located in the skeletal muscle. What's common between the two is just contraction, the contraction of the muscles. When the muscles are contracting, they squeeze on the blood vessels and essentially momentarily block the blood flow when they squeeze on the blood vessels. But the difference between the skeletal muscle and the cardiac is that for the cardiac, the coronary blood flow is blocked every 800 milliseconds because the heart doesn't stop. When it stops, of course, there are consequences, okay? And like we said last time, if you follow the red line here, okay, and we've divided, this is cardiac cycle, so there's systole and the diastole. And so at the beginning of the systole, when it contracts, when the cardiac muscles are contracting, there is a zero. There is a momentarily zero blood flow when the coronary arteries are compressed, okay? And so this is what we call the arteriovenous oxygen difference, a mouthful term which will be made clear. Essentially, the difference in oxygen content between the arterial portion of the coronary and the venous portion of the coronary. So hold on to that term. Now, if we go to the next slide, you will see then what I'm trying to say. Okay, so this slide, let's just get oriented. So this is rest cardiac output, liters per minute. And then on this axis, we have the oxygen content of blood, okay? And then these are different tissues. These are different tissues. And the shading here is the amount of oxygen that's extracted, the amount of oxygen that's extracted from the tissue. So if you we're focusing on the heart. So if you look at the heart here, out of a total of 20 here, you will see that this is like 14 out of 20. And so this part that's not shaded is 6. So 6, and then this is 14 out of 20. What's the percentage then? The percentage, this is 70%. This is 70%. So hold on to that number. This is 70%, and then this is 30%. What does that mean? It means at rest, when the blood is flowing through the coronary artery, the heart will extract 70% of the oxygen that's coming to the heart, which then means 30% of the blood will go to the vein. In other words, to restate, it means that if you have 100 molecules of oxygen that's coming to the coronary artery at rest, the cardiac muscles will extract 70 molecules of oxygen so that you have 30 molecules remaining that then proceeds in the vein at rest. In other words, the amount of oxygen reserve is 30%. Why is this the case? Because of this disruption in the blood flow. So it's almost like, you know, we're going through the COVID-19, there's a lot of uncertainty, people are losing jobs, people are not certain about the future. So a lot of people are buying, they're stocking up. So they are stocking up because they don't know whether there will be food in the shops. So the heart is stocking up. The heart is stocking up because the flow of oxygen is being disrupted. Now, if you look at the rest of the tissues, you see they're way less than 70%. The most extreme is the kidney. The kidney is only getting 10%. So as the blood comes through in the arteries to the kidney only gets 10%. The 90% goes to the veins. Okay? And then the other tissues are in between. Now, what are the implications of this? The next slide shows now the implications. So, in other words, basically, the kidney is like, the heart is like a family that does not have a lot of income. The family that's almost living hands to mouth. Their savings in the bank is very little. Out of their salary, out of $100, they only save $30. And what happens in a rainy day? So what this slide is showing you now is a rainy day. And the rainy day in this case means if you disrupt then the flow of blood in the coronary, how is it disrupted? The plaques. When the plaques accumulate, it means that then there's less oxygen flowing to the cardiac muscles. We go back to our illustration. 100 molecules in a normal blood vessel, which has no plaques. Let's say we're having 100 molecules, and the cardiac muscles extract 70, that's what we said, and 30 molecules are saved, goes through the vein. In this case now, instead of, and this is just an illustration, instead of having 100 oxygen molecules coming through, you now have 70. You now have 70 oxygen molecules coming through the coronary artery. And since the heart is extracting 70, then it means all the 70 oxygen molecules will be extracted, leaving zero going in the vein. Now, it means then that when COVID-19, in a COVID-19 situation, such a family then is vulnerable. If they can't go to work, then they have no saving. It means they starve. Now, how do we see that in a real life situation? So such a person, if they are resting, when they are resting, depending on the extent of the plaque, if this person is resting on the couch, you don't notice anything. They're just normal, just like everybody else. But if you stress this person, or if you tell them to run up the stairs, then they're going to have a tight chest. They're going to have chest pains. Because what has happened is, because they only have 70 molecules coming in, and they have zero that's going to the veins, they are short. If you increase the demand, that 70 molecule that's coming in will not be adequate. That's the, if you push them on the stairs, that 70 will not be adequate. Or if they get stressed, that 70 is not adequate. Or if you put them on a treadmill, the 70 molecules are not adequate. So they then go into an oxygen deficit. And so to compensate for that deficit, they will switch to anaerobic respiration. So they'll move from aerobic to anaerobic. And because of moving to anaerobic respiration, the byproduct of anaerobic respiration is what? What's the byproduct of anaerobic? Did I hear anybody say something?
Lactate.
Lactic acid. And it's the lactic acid that then will cause the heart to have pain. And that's what's causing the chest pains. Okay? So the deficiency of oxygen forces the heart to switch to anaerobic. So I hope you get the point here. And again, starting from this is where it's starting from, okay? And then to compensate for this, the heart will gouge. The heart will gouge, will extract more oxygen, 70%. And the consequences is it leaves very little room, only 30% reserve. And so if you then disrupt the radius, if you put plaques, then there's less oxygen coming to the heart, and therefore there's an oxygen deficit. And that will cause the heart to switch to anaerobic if it goes on the treadmill. Okay? So what's the solution then? If there's a plaque problem, what is the solution? So there are various solutions to unblock the plaque. So the problem, the coronary heart disease, when you don't have enough oxygen, it's called myocardial ischemia. Remember, we said mia just means something in the blood. And then this IS is inadequate blood flow or inadequate oxygen. So myocardial ischemia is inadequate oxygen flow because of the radius, because of the plaques. And so there are three solutions. There are three clinical solutions to the problem. The easy one is you vasodilate. You dilate the blood vessel, and so you use nitroglycerin. You use nitroglycerin. Nitroglycerin will produce nitric oxide. Nitric oxide is a gas, and this gas is normally produced by endothelia. Remember, we've talked about endothelia, the inner lining of the heart and the blood vessels. They produce nitric oxide, and so they will cause vasodilation. So they help to solve ischemia. And then there are two more invasive procedures. These are invasive procedures. This is non-invasive. You just put it under the tongue. So sublingual tablets, you just put them under the tongue of the patient, and within a few minutes, the chest pains will go because of the vasodilation of the coronary. And then this is more invasive. It's called coronary angioplasty and stenting. So you put a catheter, in a blood vessel. That blood vessel is either on the thighs. On the thighs, you find a blood vessel in a thigh, and you insert the catheter, and it goes right to the coronary blood vessels. And then you go to the site that has plaques, and then you insert the stent, and you extend the stent, and you leave the stent in place. So the stent then is expanding, is stretching out the plaques so that they don't block, or they don't reduce the radius of the coronary blood vessels. Okay? And then the other invasive procedure is the coronary bypass. So in this case, then the surgeon or the cardiologist would take a blood vessel from the thighs and then will insert that blood vessel from the thighs, will remove the blocked coronary vessel and replace it with a vessel from the thigh. So this is the coronary bypass. Okay, so there's nothing wrong with these procedures, but they don't work too well long term. So what do we have to do? I'll show you in the next slide what we have to do. But in this slide, we talk about another heart condition. So we've started here with myocardial ischemia. So not enough blood going to the heart because of the plaques and the solutions to it. But then myocardial ischemia is like the first warning. Myocardial ischemia is a warning about something that's coming ahead. So if you don't correct this problem, which is here, these plaques will continue building up until there is a complete closure. So there's zero blood flow. In that case, then it leads then to this problem, myocardial infarction. Myocardial infarction is what we call a heart attack. So again, I want to emphasize, myocardial ischemia is a warning of the pending myocardial infarction. So in other words, if you hear somebody, either an auntie or an uncle or grandma or grandpa, or even your parents complaining about chest pains regularly, of course, like I said, there are many things that can cause a chest pain, but one of the common things is myocardial ischemia because of the plaque, okay? And so if you hear somebody complaining about this, make sure you talk to them, because if it's not corrected, they are going to go through a heart attack. Okay. What are the solutions? What are the treatments for a heart attack, and what are the treatments for myocardial ischemia that are not as invasive as coronary bypass or coronary angioplasty? We have already talked about this, but before we go to natural remedies for myocardial ischemia, let's talk about the treatments for myocardial infarction, heart attack. And I think we've talked about this as well. If you remember, you give a blood thinner, okay? So you give a blood thinner like aspirin, okay? You also give a beta blocker. We've talked about this also. Why a beta blocker? To reduce the contractions, to reduce the workload on the heart, okay? And you give morphine. Why morphine? because the heart is hurting. So the morphine will help reduce the pain. The beta blocker will reduce the workload. The contraction will be less pronounced. The blood thinners will prevent the blockage. Okay, so these are some of the treatments that I used, and also you can put a stent. All right, let's go to the natural remedies. The 3 M's, we call it the 3 M's. The 3 M's, and this has been done at the Cleveland Clinic. There's a cardiologist at the Cleveland Clinic who doesn't do stents anymore. All he does is take his heart patients to the shop, to the grocery, and he teaches them the food that they need to buy, and then he takes them to the kitchen and teaches them how to cook. And he has had almost 500,000 patients, and they don't relapse, they don't go back. But if you use stents, or bypass, and the patient has not changed their lifestyle, this will just last for a short time. And so I'm not saying you can't use stents, but if you use bypass and stents and a stent, you have to teach them to change their lifestyle. Otherwise, if they continue going to McDonald's, this will only last for a short time. So let's talk a little bit about the 3 M's, and you guys are familiar with the New Start. Okay, so the mouth means greens, plant-based, a variety of plant-based diet. And then the muscle means activity. And then the other M means mindset, selflessness. You can have everything in life that you want if you just help enough other people get what they want. If you have this mindset, you reduce the stress on your heart. This mindset reduces the stress on the heart. And then you are careful with what you put in your mouth. You avoid refined foods. You reduce animal products or eliminate animal products, and have a variety of whole plant-based foods and activity of the heart. Then it will help your heart be healthy. So we've already talked about this, and we've already talked about this. I want now to focus on the muscle, the cardio exercise. So I'm going to give you the formula for this, and please do share this with as many people. This is an important graph, and what this does is, if you follow this exercise, it will induce cardiac hypertrophy and will increase coronary collaterals. I'll explain what the importance of that is. Let's start with hypertrophy. we've already talked about two types of cardiac hypertrophy. There's a good one and there's a bad one. The good one is the good hypertrophy of the heart is the one that's induced in the gym, okay? Which means 30 minutes, 2 hours of exercise. The bad one, we've already talked about the bad one. The bad one is 24/7. You're locked in the gym. We've already talked about that, being locked in the gym 24/7. So that's the congestive heart failure type of hypertrophy, where the heart enlarges because of uncontrolled hypertension. So that's the bad one. Now, what we're talking about is the good one, okay? This increases the efficiency of the heart and reduces the heart rate. And so instead of having 70 heartbeats per minute at rest, you will have less. You may have 40 or 50. That's a sign that the hypertrophy that you have is the good one. All right, collaterals, what does that mean? So again, if there's aerobic exercise, the coronary will have coronary collaterals that are used as bypass. So in case there's a heart attack, so this is like an insurance for a heart attack. In case there's a heart attack, the heart would deviate the blood into the collaterals and avoid a heart attack. So that's the importance of the collaterals. Now let's look at the table. Let's look at the table. So this is the heart rate, beats per minute here. And then this is the age. Let me just move this. Can you see the age? Can you guys see the age here? I'm trying to, okay. This is the age, okay? Age in years, and then the heart rate. So for most of you, and then it gives the range. This is the training heart rate zone. Okay, in the blue shaded part is the training zone. When you go to the gym, this is where you should stay in to induce this, to induce collateral insurance against heart attack, that's collateral, and then efficiency of the heartbeat, that's the hypertrophy. So to have these two induced, you have to train, your heart rate has to be within this training heart rate zone. The lower end is 50% intensity, then this is 85% intensity, and then above the 85, this is the maximum, the age predicted maximum heart rate. You should not go beyond the age predicted maximum heart rate, okay? So you guys, most of you are on this side, okay? So most of you are probably 20 years. So your 50% intensity then is 135 beats per minute. So when you're on a treadmill, then the minimum should be 135, okay? And then at 85% intensity, you go to 185. And you should not exceed 200. Could somebody tell me the age of their dad?
My dad is 50.
Say that again.
My dad's 50.
Okay. Okay, so Kayla, your dad is 50. So what are you going to advise your dad now that you have this graph?
He should exercise between 120 and 155 beats per minute and not go beyond 170.
Okay. Okay. Anybody else? What's the age of their mom? Age of their mom? Anyone else?
My mom's 41.
Okay, 41. What are you going to tell your mom?
I'll tell her to stay within the range of 125 and 164, and then not go beyond 180.
Okay. This is the life-saving. This is the life-saving table. It looks very simple. Remember, what you're doing is inducing hypertrophy, healthy hypertrophy, and then insurance against a heart attack. That's basically what this is doing. Okay? All right. Now we go to cardiac cycle. This is a very busy slide, but we've covered most of the things, so don't let it intimidate you. Some of the things we have not covered yet. So to start off, this is divided into systole and diastole. And so this is one complete cardiac cycle. Remember, we said cardiac cycle oscillates between ejecting the blood, systole, relaxing, refilling, that's diastole. And you can see that there's a difference in the duration. So total at rest, 800 milliseconds. Systole is only 300 milliseconds. Diastole, 500 milliseconds. Now, I want you to remember what I'm going to say. The diastole, the 500 milliseconds at rest, this is at rest. This is the only time your heart goes on vacation. This is the only vacation your heart has, 500 milliseconds. Why am I saying that? You can do certain things that can take that break away, therefore increasing the tear and wear of your heart. What do I mean? Remember, I've been saying stay on the parasympathetic. For most of the day, stay on the parasympathetic, because parasympathetic is the one that's ensuring that you have 500 milliseconds of the diastole. So which means then, if you leave on the sympathetic reduces that 500 milliseconds, reduces the break. It takes away the break. and therefore increases the tear and wear of the heart. Secondly, if you drink caffeine, it reduces the 500 milliseconds. If you drink any caffeinated drinks or drinks or foods that increase the heart rate, you are taking away the vacation of the heart, and you are introducing the tear and wear. So be kind to your heart. Be kind, please. Be kind to your heart. All right. And again, forgive. And forgiveness takes away that 500 milliseconds. All right. So let's now look at the sounds. Okay. So we'll be going up like that. So the heart sounds, there are two heart sounds. There's lab, dub. The first one is lab, dub. This is, the first sound is the AV valves. AV valves closing. The second sound is the semilunar valve closing. Okay. And then the next thing is the ECG. Okay, we've already talked about ECG. And so the QRS precedes the AV, the first sound, the AV closing, okay? And then T is preceding the second sound. Remember that the valves are pressure regulated valves. They are pressure regulated, okay? What's causing the pressure? The change in the volume of the ventricles. When the ventricles contract, decrease in volume, the pressure goes up. When the ventricles expand in volume, the pressure drops. Okay, so we go to the next parameter. We're looking now at the volume in the left ventricle. Okay, so let's begin here. So this volume is the volume that's filling the left ventricle. So we have the volume is increasing here in the left ventricle because it's flowing from the left ventricle, it's moving from the left ventricle, from the left atrium to the left ventricle, okay? So what exactly is the volume? This is 80% full. It's 130 mils. 130 mils when it's 80% full, and then you have this extra volume going to 135. So this is 135 when it's full. At 80%, you have 130 mils, okay? And then, so we go to this part here when it's completely full at 135. and then it's ejected. So this is the ejection, the volume drops, and then it starts filling again. And then it's topped up. Okay, so let's now look at the names of volumes. Okay, end diastolic volume, EDV, end diastolic volume. This is the volume, this is the final volume in the left ventricle, the 135 at rest. That's the end diastolic volume. In other words, the volume at the end of diastole is end diastolic volume. Okay? What about the volume at the end of systole? Meaning the volume that remains in the heart after ejection, because the heart is not emptying everything. There is some blood that remains, which is 65 mils is remaining out of 135. So 65 is remaining. So the volume at the end of systole is end systolic volume. So 65 remains in the heart at rest from 135. Question, how much is ejected at rest? So if the total, when the left ventricle is completely full, is 135, and after ejection 65 remains, how much is being ejected?
70 milliliters.
70 mils is ejected. So we're going to give that volume a name. That volume that's ejected is called stroke volume. So stroke volume is the amount that's ejected. And these are dynamic volumes. The amount that's ejected, stroke volume, and this is important. What I'm going to say here is important. Stroke volume is the amount that the heart will eject corresponding with the metabolic demand of the tissues. In other words, if you go to the gym, the metabolic demand for oxygen goes up and stroke volume will go up, will not be 70 anymore. 70 mils is the stroke volume at rest when the demand for oxygen in the cells, especially the skeletal muscle, goes up. So the stroke volume is a dynamic volume. It changes depending on the oxygen demand. All right, let's move on. We'll come back to stroke volume when we talk about the performance of the heart, cardiac performance. All right, now we go to pressure. The last part is pressure. And pressure in 3 different chambers. Okay, so the blue, the dark blue, is the pressure in the atrium, the left atrium. Everything is left atrium, left ventricle. This slide is basically just left. We're not talking about the right atrium or right ventricle. Okay, so the blue is the blood pressure in the left atrium. And then whatever this color is, this is the pressure in the left ventricle. And then the purple one is the pressure in the aorta. in the artery, okay? Now let's start with the left ventricle because we did talk about pressure in the left ventricle. Anybody remembers? What's the systolic pressure? What's the diastolic pressure in the left ventricle? Anybody remembers? 120/0. Okay, 120/0. Where is that? Well, the 120 is here. Okay, this is the maximum pressure in the left ventricle when it's ejecting blood, and during diastole, the lowest it goes is 0. Okay, so that's the 120/0 in the left ventricle. This is diastole, and this is at the peak of systole. Okay, what's the pressure then in the aorta? Well, this is the diastole is 80, okay, the diastole, and the systolic is the same as the left ventricle. So therefore, we have 120/80. So the systolic is the same as the left ventricle, but the diastole is different. Okay, so 120/80, which is normally that's what we use. The pressure in the artery is 120/80. Okay, so we won't care about the left ventricle, the left atrium. Okay, that's a lot of information. I'll let you pause for questions here. Any questions? All right, let's move on. Okay, we go back to the valves. We go back to the valves and we talk about how the heart sounds. Okay, so we're looking at the normal valve. So when the normal valve is completely open, this is what you have. This is called laminar flow, because the flow of the blood molecules are parallel. They are parallel to each other, and so there is zero sound. So if you go to a river, to illustrate this point, if you go to a river which has a similar diameter for a long stretch, you will have no sound from the river because the water molecules are running parallel. They are in laminar flow. So there will be no sound coming from the river. Okay? But on this side, the stenotic valve, the narrowed valve, will have turbulent flow. There will be murmurs. So this is what you see in a river. In a river that is changing its radius. So maybe if you, I've never been to a Tauga river, if it changes its diameter in some parts of the river, it's narrowing, and then it expands and narrows. In areas where the river is narrowing, you're going to hear the sounds because there's a turbulence. And so the river will make noise. So that's the case also with an abnormal valve that's not completely opening. So there will be a turbulence, there will be a murmur. Now, below you have the normal closed valve. So when the valve is closed, there's no flow, so it will be quiet. When the valve is open, there's laminar flow, it's quiet. So in both cases, you have no sounds, no abnormal sounds. Whereas in a stenotic valve, you have turbulence flow, which are called murmurs. And in an insufficient valve, the leaky valve, there'll be a backflow. There'll be a backflow. And so this backflow produces a swish sound. There'll be a swish sound, okay? And I'll let you look at this graph carefully. And this graph is basically, it's diagnostic. So how you can diagnose a stenotic valve to an insufficient valve, and basically locate whether it's an AV valve or it's a semilunar valve. This now takes us to cardiac performance. Okay, so if you have a patient with a congestive heart failure or any abnormal heart problems, you assess their cardiac performance, their cardiac output. Okay, cardiac output is the volume of blood that the heart will pump out, will eject in liters per minute. Okay, the volume in liters and the period per minute. This is an important procedure for assessing the performance of the heart. So what are the factors that determine cardiac output? There are two: the heart rate and stroke volume. We've encountered stroke volume. So that's the amount of blood ejected per heartbeat, stroke volume. And cardiac output, blood ejected per minute. So that's why then we have heart rate. So heart rate, beats per minute, multiplied by stroke volume, mils per beat, gives you cardiac output. So you tell me, what is your cardiac output at rest? Because you know the numbers. You know the numbers of stroke volume. You know the numbers of heart rate. What is your cardiac output?
Is it 4.2 liters per minute?
Say that again.
4.2 liters per minute.
Okay, so what numbers did you use?
60 for the heart rate and 70 milliliters for the stroke volume.
Okay, thank you. Anyone else? What's their cardiac output?
$5.6.
5.6. Give us the numbers.
80 beats per minute and 70 milliliters per beat.
Okay. Anyone else?
I had 4.9,
Okay, what are the numbers?
74 beats per minute, and 70 for stroke volume.
Okay, thank you. Now, just like we said, stroke volume is dynamic and reflects the metabolic activity of the body. Cardiac output reflects the metabolic activity of the body as well. So it's a dynamic number. It reflects the oxygen demand, the changing oxygen demand by the body, but especially skeletal muscle. So your cardiac output, what the numbers you've given me now, will change when you go on a treadmill. This is at rest. The numbers you've given me is at rest. If you go to the gym, that will change. And for professional, the elite athletes, their cardiac output can go as high as 20 liters per minute. That's massive. So, but that's for the elite athletes. 20. The average is between 4 to 5 liters per minute. Okay. Now, in these last few minutes, let's look at the factors that affect heart rate. And we have already talked about that. And the factors that affect stroke volume, which therefore means the factors that affect cardiac output. Of course, you know that parasympathetic, increase in parasympathetic will put a brake on the SN node and therefore put a brake on heart rate. We've said the normal SN node is 80 to 100, but parasympathetic puts a brake and reduces the heart rate to 70, from 80 to 100 to 70, okay? We've also said sympathetic will increase, will override this 80 to 100 to 150, 200, whatever the metabolic demand is, okay? So sympathetic will put the accelerator, put the gas, sympathetic will put the brakes, okay? So these are the two factors that are influencing heart rate. What about stroke volume? It's a little bit complex. Stroke volume is influenced by the sympathetic, okay? But it's also influenced by the end diastolic volume. We've talked about this. So the volume that fills the left ventricle at the end of diastole. In other words, we shall introduce a concept later here. The volume that causes the stretch on the cardiac muscles, okay? Right at the end, the pressure that's exerted on the left ventricle before the cardiac muscles contract. So that's the end diastolic volume. Going back to childhood, if you have a balloon and you blow a balloon, you fill it with air. At the end of blowing, that's your end diastolic volume. That's the pressure that your air is putting on the balloon. Okay, then the third factor is the venous return. So these three factors impact the stroke volume: sympathetic, end diastolic volume, venous return. The sympathetic, as you can see, it's impacting three things: heart rate, stroke volume, venous return, and therefore indirectly affects end diastolic volume. Okay, and we come to the end of the lecture for today. All right, I have recorded this lecture, so I will post it so that you can listen to it. All right, goodbye everybody. Good to see you. Bye-bye, take care. So we'll see you tomorrow at 6 to 9 for those of you who are coming, and I'm going to record.